It's Dale and Neri in the back. She'll be. We're going to kind of do a dual presentation, so from the front and the back. And they're obviously from the National Department of Health, and we're going to be looking at the SVS system, the mobile phone reporting for primary healthcare facilities. So,
Cool.
Dale, I'll leave it to you.
Great. This is the stock visibility system session. We're going to whiz through it because I think we've all experienced the fact that there's no time for questions, which is frustrating. So SVS is a mobile application that was implemented based on the problem we identified that Khadija and Gavin spoke about. So can you still hear me? Yeah? Which was that we had widespread stockouts. This thing's dreadful. Widespread stockouts in about 2013, 2014, and we had zero visibility into the proverbial last mile of the supply chain. So based on that, we started implementing and testing a system that was aimed at just giving visibility, basically. So for about 2 years, since 2014, we were piloting and testing the system. This isn't an off-the-shelf system. We developed it through detailed engagements with the service provider, with the department being involved at every step of the way. It was a very detailed, iterative process. There wasn't like a ready-to-go system. Towards the middle of last year, we were in a position where we were ready to roll out nationwide, and the minister said go. And within a space of about 4 months, we went from about just under 1,000 facilities being covered to over 1,300. So, 3,100. So we are now in a situation where the whole country is covered by SVS except for a small corner towards the bottom, and they have a different system, and we're in the process of networking with them. So there's some key features for the SVS system. It uses a zero-rated channel, which means it doesn't require data or airtime at the user end, which is obviously a key thing. It's networked, so the information is immediately available through the networking. It supports geospatial mapping linked to the department's facility master data list. And it has a store and forward functionality, which means if you're in a very rural area where there isn't network, you can update the data, go outside of the area where there's no network, and then it forwards once you are in the place where there's areas. It also allows for communication. So before we had no way of communicating with primary healthcare clinics, and now we have a mechanism for every facility that has a phone. We can send SMSs to them if we need to, if there's an emergency or we need to get information to them for whatever reason. So we're going to quickly jump into a short demo of the system. Nyari, if you're cool. No? Okay, we'll come back to it. So before we start the demo, basically SVS is a mobile application that's on a cell phone that is housed in a specific PHC clinic. So the cell phone is linked to a clinic. Then the information is updated into a cloud-based environment where it's accessed through a web-based portal by people who use the information to inform decisions at whatever level they require the information. Those are the people that then liaise back with the primary healthcare healthcare workers who are in charge of the phones and updating the phones. Yes? Okay, so demo.
So I'm going to take you through quickly what the facility level staff go through when they're updating on SVS. SVS has two components, the mobile application and the web application. And the mobile application is the one that the facility staff update on. So in the top right corner, you can see the logo for NDOH SVS. So at a facility level, they'd click on that icon, and it will take them into the application. And as you can see, the facility line there, it says Facility Nyari Clinic. So this is my own little facility on the demo environment. So each facility is assigned a mobile device, and the device is not interchangeable between facilities. So then they'd select a main menu option, and that'll take them through a list of options. The main one that they go through at a facility level is the record stock levels. The view records will just show them the history, the update history on the device. facility details will just show them the facility level details, and the exit obviously will take you out of the application. The temperature records functionality is one that's not active in South Africa. It was developed for Mozambique. So they select record stock levels, and on this they have 3 options in terms of how to update. They can scan a barcode, do a single stock item, or loop through stock items. The loop through stock items will basically take them from one update to the next, according to what is on the device. Single stock item, they can update one at a time, and this is the functionality we recommend, particularly if it's outside of your reporting window, but you notice a 0 stock level on your shelf. We require them to update as soon as they come to the first realization that there is no stock on the shelf. The scan barcode is a functionality that Gavin was speaking about. So essentially, they would tap on scan barcode, and through the camera, I'm getting a lot of boldies in these. My it's the second time today, but anyway. So basically, using the camera on the device, they can scan the barcode and update on the stock items. I'm going to take you through the single stock item and focus primarily on what happens if they report a 0 stock level. So currently we have the ARV, TB, and vaccine items on the device, as well as what we call the tracer stock items. So they select a medicine category to update on, but important to mention, SVS does have the functionality to update on all items on contract. We've limited it this way in terms of staggering how we ask facility staff to update, so as to not overwhelm them, not to go from 0 to 100. So then once they've selected an ARV category, they select the next page, and that gives them the option of selecting from all of the ARVs listed on the mobile application. Then select an item and then press proceed. And the next page will, at the top of it, this is the update page. It gives a summary of the history of the last update. So in this case, it's a demo device. I haven't used it before, so there is no history recorded here. Below the table, then they start capturing the information. The first field being current stock level, and they'll enter the stock as it is in their stock room. So for the purposes of this demonstration, I'm going to enter 0. In the next field that they would select, if they had a positive stock balance, would be the expiry date. But because we don't have stock on the shelf, I'm going to skip that stage. Then stock received since the last update is the next field, and the last field is stock lost since the last update. And then they select proceed. Now, the next few steps are additional steps that you wouldn't get if you had entered a positive stock balance. And they're basically targeted at collecting information around the stock out. First question being, have you placed an order for this item that you find out of stock? So then you select one of the 2 options, yes or no. The next question being, what is the reason for the stock out? And the 3 answers that they select from is, I'm awaiting my order, or the pharmaceutical depot that I get my orders from is out of stock on this particular item, or if it's a direct delivery item, the supplier is out of stock. So they select an option. And then next question would be, do you have an alternative pack size or supplier for this stock out? And they can choose yes, alternative pack size, alternative supplier, or no, there's no alternative, and then proceed. And then it'll bring them to this summary page, which basically summarizes all of the information that they've updated, and they can, at this stage, go back and check that what they've entered is factually correct before they proceed to the next stop. Important to note, the last line there in the table is stock status red, and this links in with the color coding that we'll see on the web in terms of the geospatial mapping. And once that's done, they select accept, and then they can update on the next item. And that's the mobile application. The next thing would be the web. So this information that is updated at a facility level is then accessible from any geospatial location. All you need is a reliable internet connection and a computer and access rights, access credentials to use the system. So they would then log in and access the various reports. There's a lot of information. Obviously, with just those 4 data fields that are captured. There's so many permutations in terms of how you display that information, what reports you put out there. You can put your overstocking alerts or your overstocking reports, understocking reports, obviously your stock out reports, and your general medicines availability reports. So there's a lot of detail that goes into it and a lot of detail that comes out in terms of the web, which I won't take you through, but just to tie in with the color coding that I was speaking about earlier. On this, one of the reports is the geospatial map, which will show your facilities in space. So one thing I forgot to mention is in terms of accessing SVS, your access rights in terms of what you can view is determined by your level. You're a district manager, your sub-district manager, provincial manager. If you're a provincial manager, you see all of your provincial facilities. District, you're limited to the facilities in your district and so on and so forth. So the different color coding then speaks to the stocks data. So if you've got a red, it means that you've got a stock out of one or more items. And if you select the facility, select an icon. It'll give you the facility name. And if you click on view, it will take you into the items that have been updated. And then you can view the stock level, filter by stock level for this particular facility. And you'll see all of your zero stock updates. So remember I said as a red flags a stock out of one or more items. So when you go into the facility, it shows you which items in detail are flagging that red. And there's a whole lot more around the web that we wouldn't be able to exhaust in this session. That's the sum of it.
Okay, so Nyari has gestured to the so what of collecting the data, and obviously there's loads of analytics that can be done with the information. We've gone through this. Did we go through this? Yes, in the beginning, yeah. So we've been developing dashboards at a national level based on the information collected through SVS, based on enormous amounts of user input throughout the system, from district to province to all through the system, programs, etc. And at the moment, this is kind of the high-level dashboard that's being used. It captures both availability and reporting compliance and key metrics in those areas. So a specific province example would be Gauteng, where things are looking pretty good. As Gavin said today, we implement what some people call stretch targets. Like, we're pretty aggressive in terms of our cut-off thresholds. Gavin used 80% as the example in his talking. For SVS, it's actually 90% before you can be green. So if you're not over 90, you're not green. And then there are many areas of use for the SVS data. We're not going to go into the detail of the application of it now, but obviously it links to the so what that we were talking about earlier in the plenary session. Like, this information being available isn't sufficient, but when we start using it and seeing trends, it's helpful. And this is the specific example that Gavin spoke about with Lipinova-Ritonova, where we faced a challenge with supply from the supplier side, and we were able to use SVS data to apportion and ration stock where it was in limited supply. And so the availability of the data from SVS helped us be really targeted in our approach and be more responsive in terms of time. In the same way, over time, having access to the system and the information, although in itself isn't directly linked to reduced stockouts, we have seen reduced stockouts over time for the provinces that have it in place. So this is probably the most important slide for us. The VAN concept is not just about technology, which is why we're all here, and SVS doesn't exist as just a technological application. So when we implemented it, it was seen by some people as a bit of a panacea, and like it was going to solve everybody's problems immediately. And it actually made things worse for a while, because suddenly you could see stuff that you didn't even know was broken. And when there was no data, people were saying, well, the system, the tool's broken, and it's the system's fault. And the word system became very interesting too. And through that, it was like we had a little spotlight that was suddenly shining in all the little dark corners where there was no standard processes. There were no roles and responsibilities. Nobody knew who was meant to be doing what with this data. We'd never had information like this at our fingertips before. Suddenly, it was like, well, you've got SVS. Why aren't you doing something about it? If you've got a stock out, why aren't you doing something about it? And everyone was like, well, who must be doing and then we were parachuting in from national down into the districts and causing havoc, and it was a difficult time because we suddenly had access to information, but nobody knew quite what to do with it. And there's such fragmented systems and processes in a very complex country like South Africa, with the provincial arrangements where at a district level and even within a district, standard procedures can differ. Those of you who are from here will know that, and I'm sure other countries can relate to that. So for us, the technology is, this we say 20%, 80%, but actually, I think it's more like 10% technology, and the rest is the really hard slog to do with who's responsible for what and what are we actually doing about these things, which is, for us, what the VAN is. It's not just a layer of technology. It's about saying this is an operating model that says how we all hang together and who's responsible for what, and how technology, people, process, and policy work together to support the outcome of interest, which for us is medicine availability. So there's been huge amounts of lessons learned. If anybody has time later to catch Nyari, she can tell you stories for days about this stuff. There's some specific things. We've had a couple of interesting conversations already, but something as simple as your denominator. If you don't know what your denominator is, how are you measuring availability? And for us, the denominator is the medicine formulary, because we're ultimately trying to measure availability for everything that should be stocked must be available. And then the links into selection and RMU, and it becomes a really, really enormous, complex change process. So there are a bunch of areas where we've identified specific challenges with the SVS project, and we've got processes in place to address each of those. And I think what we would say is, echoing what Gavin said earlier, having a first step is you must have master data. Like, SVS wouldn't be possible if we didn't have everyone agreeing at least this is the master list. And we're in the lucky position in South Africa that the medicines are procured through a national, the agreements of which procurement happens are agreed at a national level, although procurement happens at a local level. So we have control over the master data in terms of medicines. So we can say this is the list. And then from there, all else flows, although in messy stages. So I think this is an important thing. And then very quickly, Gavin also gestured to the fact that we're moving forward with the idea of using the data from SVS to move to an informed push or a recommended order environment. In South Africa, we have very limited resources at primary healthcare level, and often it's the nurse or the healthcare worker who's actually also doing stock management, which isn't sustainable, especially with the patient burden that we have. So we're trying to say, how can we use technology to take that responsibility away from them to make their lives easier so that they can do what they're supposed to be doing, which is patient-facing clinical care, and not sitting in a storeroom trying to measure medicine availability. So this is the next step for us, and it links into the PMPU session. If you've already been in the PMPU session, any of you, that's where the central intelligence would be housed. And then, so generating an ideal order eventually, and eventually then also receiving stock with the SVS system. So when stock is received currently at facility level, there's no mechanism to say we did definitely receive it, except for a piece of paper, which often gets lost. So to close the loop, we have visibility. We want to be able to use the visibility to start generating informed push or recommended orders, and then ultimately also accounting for the receipt of goods so that we can close the loop and say medicine did arrive, which has implications for contract management as well. And then finally, SVS is just one of the many systems in our environment. We've had lots of discussions earlier about system stuff. South Africa is not running, or the public sector is not running on an end-to-end ERP. We've got like a patchwork of systems that we're trying to interface, phasing out where something doesn't work for us anymore, building a souped-up version of it where it does work, but it doesn't quite work. And I think the one thing we've learned is you have to use what you've got. You can't wait until there's like an ERP system that's end-to-end that makes magic, because by then people have died and it's too late. So we've really done that with our environment, as you can see. And that's it from our side. So we had less time than last.
take some questions here. Start up here.
Thank you very much. Great presentation. My name's Jeff Rowland from Gavi, and question. First of all, we're helping sponsor this program in Mozambique. You referred to it in the presentation. It has two other elements to it, which includes birth registration and associating that with immunization, drop-off rates, and then supply. It's great to see how you're using the supply component of it with mezzanine here in South Africa. And my question is around the big issue you touched upon, which is change management and people. And what was the number one element that you all implemented that was able to get people to shift away to record vis-a-vis the SVS system away from maybe paper, if that's what they were using before? And how did you get to that 3,100 facilities recording on a regular basis so easily? Thank you.
So I'll respond quickly, and then I think Nyari's got more experience in the messy process. You're going to need a mic as well, unless I kind of lean in at you. I think from the beginning, we knew that we would have a challenge and a tension between the carrot and the stick, right? And we have had some stick because we've had terrible stockouts, and this was Minister's tool to be able to be in a better position. So there was definitely a stick element of saying, this thing has to work, make it happen. And without that, I don't think we would be where we are. But then on the change management side, I think, Nyari, you can speak more to that.
So it definitely was not easy.
Yeah.
It was extremely difficult. Part of the reason being that in South Africa, pharmaceutical services operates sort of in a silo from district health services. And so to get our link to the facilities was our district pharmacists, sub-district pharmacists, who don't really have direct influence over what happens at a facility level. So one of the interventions we try to implement, which we are still in the process of doing and which is working for us really well, is to get a multi-stakeholder type engagement. So don't just focus on pharmaceutical services. Get your district health services involved as well. Get your programs managers involved. We've got information on vaccines, on ARVs, on TB medicines. There's no reason why the different programs shouldn't be accessing that information and be using it to inform their practice. So definitely engaging with all of the relevant stakeholders that are responsible for service delivery in the public primary healthcare setting was key. Yeah.
And just to add to that, I think for us, we know that there is still a long way to go in that space. And we know that, and I think somebody mentioned it from one of the countries this morning, the moment we can show if you update, you will get stock. Or if you say 0, you will get help. That's when people start understanding, I'm going to do this thing not just because you told me to, but because it benefits me and my patients. And we have a way to go with that because it can't happen overnight. So it's this balance between incentivizing like the person who's actually putting the data into the phone and making it as easy as possible for them versus some level of pressure because it is a massive change and it's not going to happen with just nice chats.
So absolutely fabulous job, and I'm very happy we don't have a stock out of baldies, as you mentioned earlier. This is fabulous, and I know we're working with GSK and MPHCDA in Nigeria to try and test the same tool in Kaduna. So my question is, what is the kind of the license cost, or what is the data use cost? Is that something that you can share? Because it's fabulous, but I'm just querying.
So I'll respond to that. So I think so. In terms of there's no license cost because it's something that was developed for the department to use, and all the agreements we've signed. It's clear that the IP belongs to the department. We have not had to test that situation yet, but I think that's the situation as it is. In terms of the cost, we have been successful in mobilizing resources because it is cost effective, and we've been able to articulate the costs relative to not having it. Obviously, it's dependent on a couple of things. And for us, going back to the 80-20 slide, the costs are to do with the change management and the process reform, and especially in a crazy devolved environment like ours where it's so complex. So it's not the technology that's going to sink or swim the project in terms of cost. Yeah.
I thank you so much. This was great. I have a related question. sort of two parts to that. One is you talked about the zero data channel. Is that something the Department of Health negotiated with the telco? And can you tell us a little bit more about that? And then I think the other one was if all the IP, I also had the same question about the licensing, but who makes changes in SVS when you need to make them? Does it go back to Mezzanine, or did they train someone on your team to make those changes? Thank you.
So I'll respond to the first question. So this process has, I mean, it is a complex situation, I guess. But the zero rated channel was part of the business offering that came. It was, we know that this thing isn't going to work unless it's zero rated. And we know there are some other apps, particularly to do with bulk SMSing and responding and stuff like that, that are incredibly costly to maintain because it's not zero rated and requires sending data out to people and stuff. So it was one of the prerequisites for the program. The department's in a position where, for example, if we were to go out on an open procurement process, we would be able to set this thing up through whatever mechanism. That's part of the specification. It has to be there for the system to exist, if that makes sense. And then in terms of the changing, there's a very close working team between the department and the team in Mezzanine. And yeah, so
There's
now
a
you
change manager, change request platform where we get a lot of input from facility users, from web users, of how they think the system can improve. The system's actually changed quite a bit in the last 2 years in terms of look and feel and all of the reports that are coming out of it. So the requests come to
national, yeah.
and then they're vetted, and then we decide, is this something that we want to implement? Because once implemented, it's
It affects
applicable
across,
to the
yeah.
whole country.
So there's
It's
one
not
instance of the
province
system.
specific. And then once we've agreed on the changes that we need, then they're sent to Mezzanine to effect, because they manage the system. Part of the fees paid to them is a service fee that includes
For maintenance
like
and change.
maintaining the change requests, maintaining the data, the server, and all of that.
Yep.
Okay, so thank you for your presentation. Again, related to costs, what were the hardware costs? Who bore the costs for the phones, for example? Was this one of those bring your device initiatives, or did you have to provide the phones for each of these health facilities? You've talked of 3,100 facilities. I'm thinking Nigeria, even if we start with a phased approach, we're looking upwards of 25,000 facilities. So those infrastructural, those hardware costs are significant. Now, if you had to provide the telephones, who takes ownership for them? Who's responsible for them? And is there a replacement plan if anything goes wrong? Because obviously without the device, then we don't get access to the data.
Yeah.
Thank you.
So I can take that one. So in terms of the fee, there's a monthly fee that is charged for the services, and that includes the device as well. So the monthly fee will be covering the services that come with SVS and the device, and it's on a 24-month contract basis. And the device is essentially the property of the Department of Health. And what we request is that all devices are registered as departmental assets, and they should be managed as a departmental asset. So your district asset management policies then kick into place in terms of if the device is lost, if it's damaged, how do you proceed in terms of that? And that covers also the replacement. Yeah.
But on that note, it's an area where we've had extended engagements and discussions because it's incredibly complex. So we've reached out to National Treasury, for example, saying, look, this is happening more and more. We are using devices more and more, and there is no nationwide approach to managing cell phones as assets. It's a province-specific and sometimes district-specific approach to district-specific approach to asset management. So it's at the moment, we're doing what we can to work within the existing systems. It's not a perfect solution, and we've looked at options for saying, like, how do we manage a central buffer or insurance fund or something for replacement phones? But it's an incredibly complex thing to set up. So at the moment, it's up to the districts to manage that and with their normal asset management processes. But we are engaging with National Treasury to find like a longer term kind of nationwide solution, because it's something that's causing more and more concern and risk. But we haven't had significant problems. Everyone says surely all the phones get stolen immediately, but They haven't been. They're still there. So.
So this will be our last question.
Okay, I'll keep it brief. You're adding stock management and you want to add more items. At what point are you going to reach a limit with the cell phone in terms of the ergonomics or the user, like how many items, how many transactions, how many things can people?
So I think what's important is what we need. What is it we need from the system at this stage, right? So there are specific data. The SVS tool is just a visibility tool. The tool isn't going to be doing stock management. It's the upstream tools that are doing those things. All that SVS is a transmission of information. So in terms of the ergonomics and the acceptability to the users of capturing multiple items, they need to be doing inventory management anyway for all the items. That is the only way we can make sure there's medicines available. So it's about saying, how do we rotate things? How do we develop protocols that makes it as easy as possible, but still gets the data we need? Because it's not just for reporting stock outs. It's ultimately for us to be able to collect data from the last mile to be able to manage upstream with the planning services. So it's complex, but at the moment for us to roll out computers to facilities it's not an option. As Gavin said, there's some facilities in the Eastern Cape that you have to walk to. There are no roads. We don't have LAN and cables and all the nice stuff. Where that makes sense, then there can be a computer. But for us, this is the best way to get the information in our current environment.